Hey everyone, welcome to The Explainer. If you're a nursing student, you are in exactly the right place. Today, we're going to break down 5 super important medical conditions you'll see in pregnancy. This is the stuff you absolutely need to know for your exams and, way more importantly, for taking great care of your patients.
So, here's the game plan for today. We're going to start with a quick look at why these conditions are such a big deal. Then we'll just go one by one, tackling the 5 heavy hitters: cervical insufficiency, hyperemesis gravidarum, iron deficiency anemia, gestational diabetes, and then we'll wrap up with hypertensive disorders. I'm going to make sure we focus on the stuff you really need to know. All right, let's get right into it. Before we jump into the nitty-gritty of each condition, we've got to set the stage, right? This first part is all about understanding the incredibly high stakes here, why this knowledge isn't just for a test, but is critical for the health of both mom and baby.
And here it is. This one sentence is pretty much the golden rule for our entire talk today. In pregnancy, things can change fast. A small issue can become a big one in no time. And you, as the nurse, you're on the front lines. You're the one who's going to notice those little changes, act on them, and keep a close eye on your patient. Seriously, this right here, this is the heart of safe maternal care.
Okay, first on our list is cervical insufficiency. The name kind of gives it away, doesn't it? It's basically when the cervix just can't hold on until the baby is full term. This is a huge and often very quiet risk for premature birth or even pregnancy loss in the second trimester.
So, what's actually going on here? Well, think of the cervix as a gatekeeper, right? It's supposed to stay shut tight until it's time for delivery. But with this condition, it starts to open up painlessly, way too early. The first step for you is to understand who's at risk for this.
And this is where your assessment skills are absolutely crucial. You need to be looking for a history of any trauma to the cervix, or, and this is a big one, a previous pregnancy loss that was described as painless dilation. Your patient might come in talking about a feeling of pelvic pressure, or maybe they have some kink-tinged discharge. The ultrasound is what confirms it, showing a short cervix or something called funneling. The go-to intervention? A cervical cerclage. It's basically a stitch that's put in around 12 to 14 weeks to help keep that gate closed.
Okay, NCLEX tip time. You've got to think like the test makers. They love to see if you can connect the dots. So if you see a question with a patient who has a history of second trimester losses and painless dilation, your brain should immediately scream cervical insufficiency, and you should be thinking about a cerclage. Lock that connection in your mind. It's a high-yield point for sure.
All right, let's move on. Our next condition, hyperemesis gravidarum, is another one that really drives home just how important early detection is. And let me tell you, this is a whole different universe from regular morning sickness. The number one thing here is knowing the difference between this and just, typical nausea in early pregnancy. Hyperemesis gravidarum is just relentless. We're talking about so much vomiting that it causes serious weight loss and dehydration. But the absolute, hands-down, key diagnostic sign, the thing that tells you this is tipped over into a serious metabolic crisis, is finding ketones in the urine. That's ketonuria. So let's really look at these labs and figure out the story they're telling. See, ketones? That means the body is literally starving. It has no more glucose to burn, so it started breaking down its own fat for fuel. A high specific gravity? That's just a fancy way of saying the patient is super dehydrated and their urine is really concentrated. Of course, you'll see electrolytes like sodium and potassium drop because of all the vomiting. And here's a tricky one. The hematocrit goes up. Now, it's not because they're making more blood cells. It's because they've lost so much fluid that their blood is thicker, more concentrated.
And that brings us to the big question. What do you do first? Yeah, you're going to give them something for the nausea eventually, but the immediate threat to their life is the dehydration and the out-of-whack electrolytes. So your first move, always, is to get an IV started and pump them full of fluids. The ketones confirm how bad it is, but fixing the fluid problem is your absolute #1 priority.
All right, let's switch it up and talk about the single most common medical issue you'll see in pregnancy: iron deficiency anemia. I mean, it makes sense, right? The body's working overtime to build a whole new person and increase the mom's blood supply. It's really easy to run low on iron.
Okay, these are some numbers you just got to memorize.
Know those hemoglobin cutoffs for the different trimesters. When you talk to your patient, they're going to tell you they're exhausted, like beyond tired. But you also have to ask about something called pica. It's a classic sign, a weird craving for non-food things like ice chips, dirt, or even laundry starch. And while a pregnant person needs about 27 milligrams of iron a day, someone who's actually anemic, they're going to need a much, much higher dose to get their levels back up.
Now, for patient teaching, this is huge. To get the most bang for your buck with iron supplements, tell your patient to take them with something high in vitamin C, like a glass of orange juice. It helps the body absorb it so much better. Also, it works best on an empty stomach. Oh, and a super practical tip, you have to warn them that their stools are going to look dark, almost black. It's totally normal and expected, but if you don't tell them, they might freak out.
Okay, time to tackle a big one, and you're going to see this a lot. Gestational diabetes mellitus, or GDM. What's happening is that all those pregnancy hormones are basically causing insulin resistance, which means blood sugar levels start to climb.
As the nurse, you have got to know the difference between these two states like the back of your hand. They're both emergencies. On one side, you have hypoglycemia, or low sugar. Think shaky, clammy, sweaty, maybe a little irritable. On the other side is hyperglycemia, or high sugar. For that one, remember the 3 Ps: polydipsia, super thirsty; polyuria, peeing all the time; and polyphagia, super hungry. And you might even notice that classic fruity smell on their breath. Knowing these signs inside and out is all about keeping your patient safe.
So why is GDM such a big deal? Well, if it's not controlled, it can cause some serious problems. For the baby, we worry about macrosomia. That's a very large baby, which can lead to a traumatic birth. And then, right after birth, that baby is at a super high risk for their own blood sugar to crash. For the mom, we're looking at a higher risk of infections during pregnancy and a really high chance, like 50-50, of developing type 2 diabetes down the road.
Okay, so let's put this into practice. A baby born to a mom with GDM has been living in a high-sugar environment for months. Their little pancreas has been working in overdrive, pumping out tons of insulin. The second they're born, that sugar supply from mom is cut off, but their pancreas doesn't know that yet. It keeps making all that insulin, and boom, their blood sugar plummets. So what's your priority? Feed the baby right away. Breast, bottle, it doesn't matter. Getting that glucose in them is almost always the right answer. And finally, we've arrived at one of the most serious and complicated things you'll ever manage, the hypertensive disorders of pregnancy. This is where your assessment skills will be tested like never before. Think of this table as your roadmap through these conditions. It all starts with gestational hypertension. That's high blood pressure that shows up after 20 weeks, but with no protein in the urine. The second you see protein show up, it's officially preeclampsia. If that patient then has a seizure, it escalates to eclampsia. And then there's the really scary one, HELP syndrome. It's a life-threatening complication that you diagnose with labs: H for hemolysis, EL for elevated liver enzymes, and LP for low platelets. You have to understand how one condition can progress to the next.
Okay, so when a patient has severe preeclampsia, we give them magnesium sulfate. Now listen closely. It's not a blood pressure medicine. Its job is to act as a depressant on the central nervous system to prevent seizures. That's its only job. So your nursing care becomes completely focused on one thing: watching for signs of toxicity. You're checking their respiratory rate, their deep tendon reflexes, and their urine output like a hawk. And you absolutely positively must know where the antidote, calcium gluconate, is at all times.
This right here, this is the ultimate NCLEX safety question. If you're assessing your patient on mag sulfate and you find that their deep tendon reflexes are absent, that's a huge red flag for toxicity. It's an emergency. Your immediate priority action is to stop the infusion. Hit the pause button on that pump first. Then you get ready to give the calcium gluconate. But the first step is always stop the mag.
And you know, this really brings us to the true heart of what we do as nurses. We've gone through all the science, the lab values, the test-taking tips, but none of that is worth anything if your patient is too scared to tell you about the headache that won't go away or that their vision is getting a little blurry.
Your clinical knowledge is the foundation, for sure. But your ability to connect with another human being, to build that trust, that's what really saves lives. So just keep that in mind as you start your careers.